哦，好，咁你可以點埋梁議員先嘅。好啦，咁多謝各位。
Alright, we've got a quorum already, so may I now call the meeting to order. So let's invite the administration in. And let me say this, these two members. At the last meeting, some members, in particular Mr. Joseph Lee, said that an introduction on the electronic healthcare or health record sharing system be given to members. I believe some members know the system very well. In fact, a few months ago, the health services panel paid a site visit to the center, but of course not all members joined the visit. So this is the first item on the agenda. We'll receive an introduction from the administration on the electronic health record sharing system. And then I believe members have received the following papers. First of all, the administration's response to issues raised at the meeting on the 13th of May, and also the administration's response to issues raised at the meeting held on the 19th of May. I will not read out the serial numbers of the papers. And then there is the administration's response to issues of concerns raised by the Privacy Commission and other deputations in respect of privacy protection in the e-health record sharing system at the meeting on the 26th of May. And then we've also received the administration's response to other follow-up issues raised at the meeting on the 26th of May. We all want the Privacy Commissioner to come more often to address our concerns on privacy matters. I understand that in the coming month, the Privacy Commissioner will be out of town during certain periods, and so we've scheduled a meeting with the Privacy Commissioner on the 24th of June, and that's the earliest possible date for another meeting with the Privacy Commissioner and his staff. And so concerning issues raised by insurers and the Privacy Commissioner on the safe deposit box, rather on the safe deposit box, I mean, please try to find time to attend that meeting and exchange views with the Commissioner. All right, so much for the meeting to be held on the 24th of June. And now I'll hand over to Mr. Sidney Chan, head of the e-health record office, to give us an introduction on the e-health record sharing system. Yes, thank you. We've prepared a 7-minute video on how the system operates in a private clinic setting. And in fact, this video will be shown to members of the public at future briefings and consultation sessions. And after members have watched the video, you will be shown about 20 slides. In the slides, we try to address the concerns raised by members. So we want to give members an idea of the of our flow chart and also the work procedures. So perhaps we'll watch the video first. Good morning, Dr. Zhang. Please be seated. Yes. Good morning, Mr. Chow. This is the first time I see you, so how can I help you? I feel unwell concerning my my chest on the right side, and I've got some rashes, and I also feel itchy. All right, let me have a body check for you. Right, so you need not be worried. In fact, it's not heart disease. I believe you've got shingles. So I'll prescribe you with some medicine. Now, do you have some existing diseases or allergies to drugs? I have diabetes, and I go to a private hospital for regular follow-up consultation. And on one occasion, I told the doctor that I had rashes after I had taken a certain drug, but I can't remember the name of the drug. But have you brought along the name of the drug, or have you has the doctor given you the prescription? No, because I thought I would only be seeing the doctor this time for the skin problem and also the heart problem. So I took part in a scheme administered by Admiralty Hospital. So we'll be able to have access to my health records. Now, but my clinic has joined the electronic health record sharing system. But then it doesn't mean that I can automatically gain access to your records. I have to have your authorization. So do you agree to my having access to your health records? Because you need to give sharing consent. Yes, I give my consent. All right, so let's now go through a simple registration procedure. So please insert your ID card into the reader. And then please remove your ID card. Now the registration has already been completed. Oh, I've received an SMS telling me that the authorization has become effective. So that's very convenient. Yes, in fact, every time any doctor or any medical organization gains access to your health records, you'll receive an SMS, and as a result, people can't. You know whether people have tried to gain access to your records. Yes, it's really very secure. When you gain access to my records, I immediately receive an SMS. So will there be unauthorized access to my records? We have to abide by the Personal Data Privacy Ordinance and the relevant ordinance, and will not disclose your information or details to others. And in fact, in future, you can you have the right to withdraw from the scheme or to stop a particular medical organization from having access to your records. All right, let me now take a look at your records. So you are allergic to this drug. You need not worry. So it seems that your problem has not got anything with the drug, but it seems that your kidney function or renal function is not very good. Are you aware of that? Is it that you can't have access to my information concerning my renal functions? Because I'm going to prescribe you with medicine on shingles, and I need to take into account this. But I have to get your consent. In fact, a lot of information can be shared, including test records, diagnostic records, medical records, and so on and so forth. And if we can have access to all these records, then that will facilitate the doctors giving treatment to you. All right, let me have a look at your blood test and your renal function. You've just had a blood test, and the kidney function index is not too bad, and I don't think you need to undergo another blood test again. All right, I'll, according to your conditions, prescribe you with the right dosage. All right, do you have further questions, Dr. Zhao? I've already consumed all my diabetes drugs. Can you prescribe me with some? Yes, I can, because the types of drugs you are using for diabetes are shown in the medical records or your health records. All right, so Dr. Chow, that's the end of this consultation session. So the consultation today will be recorded and uploaded onto your records. You need not be worried. My system and the electronic health record sharing system are two separate systems. Only information relating to the shareable scope within the shareable scope will be uploaded. You can master the computer very well. In fact, we are now only at stage 1, and we are having some functions. And in the second phase, there will be more functions. So I think we should err on the cautious side. And I think it's good that such a system can help both doctors and patients. Now, I'll ask my colleague to tell members more about the background of the spill. Yes, Chairman. So let me take members through the important principles behind the system and the more important functions. Now, in fact, there are two phases. In 2009, LegCo approved funding for phase 1 of the e-health record sharing system. And phase 1 is from 2009 to 2014, so we're in the 5th year. So under phase 1, there is a need to provide the core infrastructure for a sharing platform, providing the basic functions. I want to say that the user acceptance test has already been completed, and the technology development part has also been completed. And we need to make sure that private hospitals can connect themselves to the platform. And the clinical management system for use by private clinics has also been completed. And then concerning the names of the drugs, the names of the diseases, of course there is a need for standardization, and also there is a need for interfacing. And these have already been completed as well. And some have said that there should be protection over and above that provided for in the Personal Data Privacy Ordinance. And that's why we've got the spill providing for more protection.
This is the timetable for the different stages. Prior to 2009, preparation work was undertaken to test the concept of the shareable electronic system. We have the PPI-EPER public-private interface electronic patient record program. Through participating private practitioners, electronic health record within the hospital authority system would be accessible. And this is in preparation for the development of the first stage. At the end of 2010, we conducted a consultation, and the results have been reflected in the development of the first stage. Now we're in 2014. With the endorsement of the bill, we will be able to start the operation of the EHR sharing system, SS. This will take the place of PPI-EPR by providing a platform for public and private clinics and hospitals to access electronic health records. The second stage development is to enhance additional functions, which include the expansion of the shareable scope, say for example, increase the addition of radiological images sharing, some other enhanced functions, and the installation of safe deposit box. When it comes to the PPI-EPR, it provides us with valuable experience to develop the EHRSS platform. When it was first launched in 2006, there were 10,000 patients participating. Now we have over 360,000 patients and 3,200 healthcare professionals participating. Most of them are in the private sector. In relation to this program, in 2013, we commissioned the Chinese university to conduct a survey. We found that most of the participating patients and practitioners are satisfied with the program. We have taken reference from this valuable experience in the development of the current system. Advantages of the first stage system. It means that all participating patients will benefit. We don't aim at a full launch, but at least in the first stage, elderly patients and children patients will benefit, because for the former group, they have a bigger need for health care, and very often they are frequent visitors of private and public healthcare system. So this sharing platform will benefit them a lot. Whereas for children patients, if it starts at an early stage, that is the electronic health record, the information will follow them and will accumulate, which in turn will benefit the patient. And we also think that this will promote cooperation between private and public sectors. For patients, this reduces repeat tests and examinations, which in turn saves time, cost, inconvenience, and risk. Because for patients, repeated tests is an ordeal, because you have to conduct numerous types of endoscopes. This will cost them money and itself is not a nice experience. Medication information is also for sharing in this platform, so this will reduce the risk of the wrong use of drugs or allergy. All in all, this will provide a more consistent and quality medical service and timely diagnosis and treatment for patients. In the second stage, we have to seek additional funding from the LegCo. As I said, there are a number of elements under this program, including expansion of the scope and enhancement of a number of functions, and the introduction and the study on safe deposit box. We heard from the public consultation that there are views supporting and objecting to the installation of safe deposit box. I'm not going to go through the views as members have heard them in the public hearing. During the stage of the funding application in 2009, safe deposit box was not included. This is first floated in the public consultation in 2012 and 2014. However, views were divergent. And these views are similar to the public views expressed in the public hearing earlier. In June 2012, we reported the consultation result to the Health Services Panel. And we also would like to take reference from overseas experience. So we will conduct a detailed study on the function of the safe deposit box in the second stage. There are a number of issues to be addressed of a safety deposit box. We have to address the concerns of patient groups. In the public consultation, we find that healthcare professionals have come up with a number of issues to be addressed under safe deposit box. The usability of the system and whether is something we have to take into account, and at the same time balance it with complexity of the system. We have seen from overseas experience that they have offered a very complicated multifunction system, but no one is using it because it's too complicated. So we have to strike a balance. We also have to take into account control and access of sensitive data. There are a number of ways to deal with them, each with merit and demerit. Maybe one option can address one concern, whereas another option will address other concerns. We will look at the advantage and the merit and demerit of each option and the application in Hong Kong. There are many different designs of under the different options. We also have to consider who will decide what information is put in the safe deposit box, doctors, patients, or both. What is the definition of sensitive data? Those viewed by patients? Or will there be data that should, under all circumstances, be made viewable? What will the information? How will the information be dealt with when one is kept in the safe deposit box, and who have access and how? There is another issue. That is, we see from overseas experience that there are many different approaches in overseas experience. Whether we show the existence of the safety deposit box, and whether access and deposit retrieval or deposit is shown. And we also have to take into account possible risks of legal risks related to healthcare. And initial information shows that the experience from overseas is not very successful. Well, I must say that the overseas experience are information we found from a desktop research. We will engage an expert to conduct a detailed study to look in depth into these issues. It will take time to research, design, and develop the system, so it will not be put in place within a short time. We already have the technology, but there are many other issues to be dealt with. And I would like to talk about some major principles in the EHRSS. It's also set out in the cloud consultation in the end of 2011. The PCPD has also indicated that there are a number of issues and not explicitly written in these principles. These principles include PDPO and some other controls and regulations and safeguards. Some are built in the system, say for example retrieval and access or viewing control, and we have to let patients know what is meant by participating in the system. We give them patient notice, setting out patients' rights and general information about the procedure. At the end of 2011, we found that all these views have been generally supported by the public. There are two levels of consent. One is joining consent. It's not worded so in the consultation document. In the bill, there is a provision indicating that when you join, you have to give a consent. For a clinic to access your data, you will have to give them sharing consent. It's reflected in the workflow. Well, we have to reflect in the principle that there are consents given. There is the sharing consent, which is in the hand of the patient. The patient will decide whether the information should be made available to a particular healthcare professional. And at any time, say several years later, when the patient stops seeing that particular doctor, the sharing consent can be withdrawn. And in relation to the use of the EHRSS, the use is in general forbidden unless you prove that the information is used to provide a health care service. This reflects the need-to-know principle. We have to strike a balance between that and privacy. The information will be for the use of healthcare professionals. So the professionals will decide how much information is required clinically. And in the bill, we have set out provisions related to privacy protection and the use of data. Of course, we will take the clinical considerations of healthcare professionals in the provision. And there is also the shareable scope under the system. There is also safeguards put in place by the administration. We also have a commissioner. It's to be appointed by the administration, and it will be a public office. On top of that, it should be multifunction and technology neutral. We will not set the type of technology and function of the system because it may change in the future. There is a very important principle, consent, a two-level consent. The patient may choose to join or not. Once you've joined, it doesn't mean that immediately your data will be viewable by medical practitioners because you have to give a second-level consent. Say, for example, a patient has seen at different clinics. The patient may choose who will receive a sharing consent. Clinics or practitioners with the consent are the only ones who can view and access such information. In relation to the shareable scope, it doesn't mean that all information in the clinic is made shareable. Only 9 types are available. They are necessary to the provision of healthcare services or treatment or diagnosis. The setting of the shareable scope. At a very early stage, we have already looked into that.
Now, of course, we need to take into account the clinical needs. And in establishing the clinical needs, we need to involve the experts. I'll go into this in greater detail. And then second, we have to make reference to international standards of record sharing. Sorry, there are no Chinese translations for these standards, but I believe those in the field know these standards very well. And then we have expert groups under the steering committee making recommendations on the shareable scope. And of course, we will also make reference to overseas experience and also the PPI-EPR. In fact, the shareable scope can be found in the consultation exercise and is also available on our website. I mean the Health Record Officer's website. So the details are available on the website. As I have said just now, we need a lot of input from the experts in delineating the shareable scope. Under the steering committee, there are many working groups or expert groups. And you can see that concerning drug records, immunization records, test records, we have special working groups for each of these. And then we decide on the shareable scope. I'll not go into the details on concerning this slide. I just want to tell members that there are many working groups or expert groups, and there is also a lot of participation by the private sector and the public sector, including patient groups, medical organizations, IT experts, and so on and so forth. And there are about a total of 200 people giving their input at these various groups. Members may want to know more about the interaction between the e-health record sharing system and the systems of the participants. Now the orange part represents the EHR sharing system, and then the blue parts or circles represent the health record systems of different organizations, the Department of Health, the Hospital Authority, private hospitals, private clinics, and so on and so forth. So they can upload their records onto the sharing system, but they can and only records in the 9 area I've just mentioned will be uploaded onto the sharing system. The other records will be kept by the participants themselves. So this sharing system will not replace the systems now kept by the different organizations or participants. In the in the sharing system, only the more important information or data is shared. And the participants cannot share information among themselves. For example, a private clinic cannot have access to the medical records of Mr. XYZ kept by a private hospital. And the sharing system is the yellow or the orange part, not the blue parts. And I want to say that at the moment, these blue platforms are already governed by the Personal Data Privacy Ordinance. So even without the sharing system, there is still monitoring of the operation of these blue systems existing at the moment. And this future sharing system or platform will also be subject to the Personal Data Privacy Ordinance. And concerning regulatory control on the use of electronic health records, of course, we have the legislation, including this bill and other relevant pieces of local legislation. And then we have policies of operation, codes of practice, guidelines, registration, specifications, and so on and so forth. And of course, there are also standards and specifications which need to be observed. So, as I have said just now, the existing systems and the future sharing system will be subject to the Personal Data Privacy Ordinance, and the 6 principles, data protection principles will apply. And in designing our system, we have other safeguards for privacy protection. Now, first of all, the patient can voluntarily take part in the system, and the patient has a choice. The patient can decide which record to be made accessible by a certain medical organization, and also there are retrieval restrictions. We are mainly talking about the 13 healthcare professionals, the 13 categories who can have access, who can view the records. And also there is the SMS sent to the patients. In fact, this function is already in the PPR, EPR, and the patients like this function. In other words, if anyone gains access to the his or her health records, he or she will be sent an SMS. And of course, the healthcare professionals have to comply with their professional codes of conduct, and the commissioner can also issue circulars, guidelines, and codes of practice, and there will also be privacy impact assessments. There will be 3 stages. Stage 1 will be on the trial scheme, and then stage 2 will be on the privacy assessment. And according to the experts, the present design has not violated concerns, or has not violated the relevant provisions. And concerning stage 3, the experts have not detected any serious problems so far. And after the commissioning of the system, we're going to carry out a privacy compliance audit. We need to know whether the operation of the system can really fulfill the data protection requirements. And the information is only viewable to healthcare professionals, those who are taking care of the patients, and not those who are not treating the patients. So with the SMS alert, the patient will know who has tried to gain access to his or her records. And also, if any healthcare professional wants to access the system, his identity, his status has to be verified. For example, whether he is still a registered healthcare professional, and so on and so forth. And of course, the SMS alert is also very useful. And also for all accesses to the records, there will be records and also auditing. And let me now say something about the security features. The identity of the patient and the healthcare professional has to be verified. Now, for the patient, we need the ID card, and for healthcare professionals, we also need the e-token and a password. When information is transmitted on the internet, there is encryption, and there is a need for an electronic signature, and there will be firewalls. There will be systems to guard against viruses or hacking, and also there will be security risk assessments. There will also be security audits and also transaction record audits. And members may also be concerned about the accuracy of the records or of the content of the records. Now, the healthcare professionals or healthcare providers provide the healthcare records and then they upload the records onto the sharing system. So the healthcare providers or the healthcare professionals are the ones providing the healthcare records. They have to make sure that their content is correct and accurate. Because in fact there are codes of practice laid down for the Department of Health, private hospitals, nursing homes and maternity homes. And then for healthcare professionals, as they are registered healthcare professionals under the law, they need to comply with the professional codes of practice promulgated by their respective professional bodies. And these guidelines or codes do require that health records provided by them must be accurate. And the commissioner is in fact the manager and the operator of the system. And the commissioner has to make sure that the health records belong to Mr. ABC will not be wrongly put under Mr. XYZ. But then the commissioner cannot ascertain the accuracy or otherwise of the content of the records. For example, whether Mr. XYZ did undergo an operation at a certain private hospital in 2013 or whether this patient was prescribed a certain drug by a certain doctor on a certain date. So the commissioner can't ascertain the accuracy or otherwise of the content of the records. The accuracy of the content of the records is the responsibility of the healthcare professionals concerned. The commissioner does not inspect the record systems kept by the healthcare providers. And what's more, not all patients would join the sharing system, and so the systems provide or kept by the individual healthcare providers may contain other information not included in the sharing system. For example, the information belonging to the staff or information belonging to those patients who haven't joined the sharing system. And the commissioner cannot check the accuracy of the content of the records kept by individual healthcare providers. But then we can do something concerning the quality of the data.
We have to abide by the requirements under PDPO. We will set the standard and format of information shared. The connectivity requirements of the system is also preset. We will also put in place guidelines and specifications. When it comes to verification and test of the system, we will do that. Detection of virus and malware is also something we're going to do. We'll also put in place IT security policies to ensure security. Last, I'd like to talk to you about the governance chart. This will be under the leadership of the administration. We will appoint an EHR commissioner who is a public officer. The commissioner is accountable to the Secretary for Food and Health. You see, there are different units under the commissioner. Say, for example, Infrastructure and Development Unit, Policy and Planning Unit, etc. There are also secondees of hospital authority. You see that on the left-hand side, there is an advisory structure which is currently in place. There is a steering committee with various working groups on different areas, giving recommendations to the permanent secretary and the secretary. And you see on the right-hand side is the research board, which is also mentioned in the bill. They will look into the use of data for research purpose. Applications will be made to this board if someone wants to use the data for research purpose. There are also participations of different stakeholders, working groups, pilot schemes and cooperation schemes. We also have healthcare professional groups and patient groups participating. This is the end of my presentation. I'll be happy to take questions from members. Thank you. For the detailed presentation of the entire scheme, perhaps it's something that should have been done at the outset. We have Dr. Joseph Lee. Upon your request, we have already had the presentation. It doesn't matter that you've just joined us because you're very familiar with it. There are a number of meetings taking place at the same time, so maybe some members are unable to join us. Anyway, we will give time for members to ask questions. Two members have raised their hands, and I want to know first if the administration would like to go over the responses of issues raised. I think it may be better to answer questions of members. There are issues related to the safe deposit box and privacy. Perhaps you may want to put these questions on hold till the later meeting on the 24th of June, where we have the PCPD with us. First, Dr. Lang Kalau. Clause 3. C1213. In relation to children and mentally incapacitated person, there is the arrangement of a substitution decision maker. Say 3 bracket 2, clause 3(2). There is a list. Say, for example, well, let me talk about subclause 3. There are 2. One is mentally incapacitated and the other one is not. Can you maybe make your questions clear? Say C1215, a mentally incapacitated person. Say subclause 4. Say there are 2 sons of the mentally incapacitated person. One son says, well, it should be viewable. The other said no. And the patient is in a coma. What is to be done? The arrangement of substitute decision maker. First, the patient will have to participate in the scheme if it's minor or mentally incapacitated. There are a number of people who can make decisions for them. And they have been put in a specific order, say a parent, then guardian, to be followed by people appointed by the court, then family members, and then the clinic. If it's group 4, say family members. Say there is an elder sister and an elder brother. Who is to take precedence? We have considered that when drafting the bill. I think you know that it's difficult for us to decide who is to take precedence, whether it's an elder brother before a younger brother. There is actually time for family members to have discussions. Say if it's a non-urgent operation. The current practice in the hospital authority is for family members to work out a solution. Well, I've been doing frontline work for a very long time. I know that the current practice is very different from this substitute decision maker arrangement. That's why I asked a question. In CAP 136, section 55ZF, is actually the doctor who makes a decision. Whether it's an emergency or not. If the patient does not have the ability to make a decision, then it's for the doctor to make a decision in relation to a medical procedure. And if this is to be decided by if an important medical procedure is to be decided by the doctor, well, but it's not mentioned in the bill. Have you considered the arrangement under section 59ZF of CAP 136? It says it's a mental health ordinance, CAP 136, those defined as mentally incapacitated. Have you taken reference from that chapter? The Law Reform Committee looked into substitute decision maker. There are inadequacies in the current practice and there are some recommendations. As far as I know, there has been no change. Under current legislation is the doctor or the dentist who makes the decision. Thank you. I try to explain that the arrangement of substitute decision maker is not in an emergency when the patient has to be rescued. When there is no time for family members to have a discussion and work out a solution. We're talking about at the time when a decision is to be made as to whether to participate in the program. We have put parents before guardian, before family members, but we have not decided. But we don't decide whether an elder sister will go before an elder brother or not, because we would like the family members to discuss and work it out themselves. But it may be an emergency. Yes, in the bill it doesn't specify whether it's an emergency or not. It just mentions substitute decision maker to give joining consent, sharing consent, withdrawal. It doesn't specify whether it's an emergency or not. And well, for CAP 136, section 59 EZF, it doesn't specify whether it's an emergency or not. It says if the doctor or the dentist is of the view that the patient has to receive treatment, there is no need to get consent from the patient. It seems that you don't know about this arrangement at all. I can print this out for you. What is to happen? Is section 59 EZF. But I think it's a matter of whether it's the participation or treatment. I think the difference is that for CAP 136 is is a treatment procedure. Of course, when a decision cannot be made, it has to be made by the doctor. But under the bill, in this clause, it talks about substitute decision maker. It's about the decision to participate or not a treatment. And under the bill, the arrangement of substitute decision maker does not affect the arrangement under Cap 136. The current practice, that is, when a doctor can make a decision, is not affected. This is in relation to the time when a decision of participation is to be made in an emergency, and when the patient does not participate in the program. Well, it may not be an emergency when the patient decides whether to participate or not. But in a case when the patient, say for example, is in a coma, and a decision is to be made as to whether to participate or not, well, there is an exemption under the PDPO in an emergency situation, and this also applies to the EHR. So don't worry if it's an emergency for the sake of treatment, the data can be viewed. Then the family members may have a discussion as to whether to participate in general. Perhaps I would defer to the hospital authority. Dr. Zhang.
I think it's already been explained. If there's an emergency where the doctor considers it would be life-saving to access the patient's electronic record, even if the patient hasn't given access and there's no family member, or if there's a dispute among the family members, the doctor can, we call it breaking the glass. It's like, with an emergency alarm bell, he can break the glass and get access without that patient's consent, because the patient's incapable of giving consent. But it has to be deemed to be, an emergency in the doctor's professional opinion, and that's covered by the PDPO. So it doesn't need to be covered in this law.
This is not logical. I don't understand. I don't know whether the bill caters for the situation that is an emergency. Perhaps I will talk to you further if I have a chance to meet you, to see you. When it comes to treatment or doing an operation, there are circumstances when the consent of the patient is not required. I don't think there should be so many restrictions when it comes to just the viewing of data. I suggest the arrangement of the substitute decision maker should mirror the arrangements of other pieces of legislation. I think there is some kind of reform committee who has come up with a report with many recommendations. It's a report that is over 200 pages.
Yes, I do welcome some more background information from Dr. Leung. But here we're talking about the definition of those who can give consent. And say if there's someone who wants to join the scheme, say if he is a child or he is a mentally incapacitated person, then a substitute decision maker is required, and that's what we have under 4A to G. And the substitute decision maker can decide, say, which hospital out of the 6, for example, can get authorization to access the records. And the bill does not affect the doctor's right to say perform an operation on a patient in a case of emergency. I think Dr. Leung is saying that as there are the two pieces of legislation, can they be written in a consistent manner? I believe Dr. Leung is not really worried that there may be problems here, but Dr. Leung is just suggesting consistency. Perhaps we can go back and look at those provisions on the substitute decision makers. Yes, please look at the existing arrangements under the law, the present law, I mean. Say an elderly person may have 5 to 6 children, and who can have the say? Now we understand that at the moment is that for the doctor to act in the best interest of the patient, because the doctor doesn't know the ties between the patient and his family members. You know, such ties can be rather complicated. Now you're saying that this one will not affect the other one, but then what if the doctor wants to perform an operation on the patient and the family members do not agree, and yet the doctor may not be able to have access to certain records? You know, the family members disagree, and so the doctor has to bear a very high risk in making the decision. But then it's illogical that the doctor, having to bear such a high risk, cannot have access to certain records of the patient because he is at the end of this list. Now, if I need to gain access to the records and I go by the PDPO, and then CAP 136, that allows me to give treatment to the patient. And I really don't know when that can be done. Now, I want to say that we unless we're not following the PDPO, we follow the if we do not follow the PDPO, we'll write it down here. Under the PDPO, the doctor can give emergency treatment to the patient. There's no need for me to lay this down again here. I think you can look at this and respond. I'll not set a time limit for members to ask questions because there aren't too many members here, and we do have plenty of time at this meeting. Mr. Lo Wai Kwok, Chairman. Now, I think, Chairman, this briefing is very useful, and in fact it should have been given to us at the first meeting of the Bills Committee. And I think with this briefing we know that in fact operational experience and has been gained under the trial scheme. But of course we'll still scrutinize the bill very carefully. And all the provisions and the arrangements. In 2013, CU Hong Kong carried out a survey. And I'm not just interested in who are satisfied. 76% of the patients and also over 60% of the doctors who took part in the survey said that they were happy with the e-health record sharing system. I want to have an executive summary of the survey report. I'm interested in the comments made and also some of the suggested suggestions for improvements. So I believe having an executive summary of the report will be helpful. So can you give us the information next time? Yes. Yes, Mr. Chen Hang-pan. Thank you. Yes, now we know more about the detailed operation and the effectiveness of the system. So last time at the public hearing, concerns were raised concerning the safe deposit box arrangement. And it is said in the briefing that this concept will be studied only in stage 2. I want to know whether the study will be a study from step 1, or is it that in fact some research has already been done? Yes, Mr. Chen, thank you. In fact, there were 2 schools of thought. In 2012, in the consultation exercise and also during last week's hearing, there were both schools of thought expressed. And after the public consultation in 2012, we reported back to the HS panel, and we said that the matter was not as simple as some might think, because we need to have the support of the patients as well as the healthcare providers. And we won't be able to implement the safe deposit box if we can't have the support of both groups. I understand that in some countries they do withhold some information, but then there are different approaches. In some cases, all such information is withheld, and in other cases, there can be discussion with the doctor and the patient, and so we can see that problems were encountered in many countries, and we haven't seen an example which is very successful. And as a result, we are of the view that as there are divergent views, we need to carry out a more detailed study. We need to look at the design, possible designs, and how the problems can be addressed. And then we will seek the views of the stakeholders. And in fact, we are already in the 5th year of the phase 1, and we are of the view that we will start a study as soon as we enter phase 2. Yes, it's true that there were problems, or there are problems in the implementation of the safe deposit box in many countries, and yet there is this system in many countries. So in fact, these countries did feel that there was a need for a safe deposit box system, although a perfect solution has yet to be found. Yes, we won't have the safe deposit box in phase 1, and we do agree that this should be tried out. But we need to let the public have confidence in the system. and we want you to carry out the study, and we want to see the government's sincerity in implementing a safe deposit box system. We don't want you to just carelessly or casually carry out some research. Yes, there will be a detailed study in the first year of phase 2. And in fact, in the light of concerns in society, we've done some preliminary studies. So as to whether all the information in the safe deposit box should be blacked out, only some of it, and then second, who is to make a decision, the patient, the doctor, or or discussion, or upon discussion with the between the doctor and the patient, and also there can be other scenarios. For example, some information has been blacked out, but this is not known to the parties concerned or to those who have access to the records, or there can maybe some information which may be blacked out, and there is a red asterisk, for example, to show that the information is not complete. Yes, there can be a lot of arrangements. Now, Dr. Zhang is our technical consultant, and so I think he can tell you the considerations behind studying the safe deposit box system.
I think that the issue here is that there's a lot of different ways to achieve safety deposit-like feature, and there's because there's so many different options, we can't really say we'll build it now because we don't know what it is that we're building until we've done the study and understand how Hong Kong wants to proceed with this. What I can say, though, is if after the study and we come to an agreement on the model and we think we find a workable one, which, to be honest, may or may not be possible, but if we do find a workable model, then certainly we can build it. I mean, that's something that we can include in the phase 2 plans. But we really have to know what it is before we build it. Otherwise, we spend a lot of money building stuff which won't be used because we end up with choosing a different model, or else somehow attempt to build all models, which would be very expensive. So I think it's important to find the workable model first before we really delve into the technical details. But having said that, because the whole system was built by us from scratch in the first place, we have confidence that we could do it once we know how we want to do it.
主席，我諗咧就我講清。
I want to state my suggestion more clearly. For phase 1, under phase 1, we don't have the safe deposit box, and as a result, some members of the public may not feel confident about the system. So what I mean is you should not just carry out a study as to whether you are going to implement a safe deposit box system. I mean, you also must start studying the program, and then you also study whether you are going to adopt the safe deposit box system.
I believe that you don't need much effort or time to put the safe deposit box in order. You need a safe deposit box function in the system, and whether it will actually be put to use, it depends on the outcome of the study. But at least we should have that function in the system. This will instill confidence in users. If you say, well, there will be consultation, but we won't know whether it will actually go ahead, I think that will be problematic. I think Dr. Zhang has answered your questions. There is a difficulty. They don't even know what to build. There may be 18 different scenarios, and if they build 18 models and then decide which one to choose, that will be infeasible. And there is also the funding problem. I think that it is not covered by funding sought previously. They can't come to us asking for funding to build something, but they don't know what this thing is. If they have to build 18 models to choose from, I think there is a problem. I think what the member is saying is whether it can be expedited and whether certain things can be done in tandem. Well, I want to clarify that I'm not asking for 18 different models, but you see a general framework of the deposit box. Well, technology or technicality is never a problem, but at least the administration should show us that they are sincere in putting this in place. We don't want to see it not being put to use after consultation. So you need to show us that you will start working on the infrastructure, on the basics. Then you conduct studies. We need to see that you have started doing something. I have a question, a follow-up from Mr. Chan's question. Perhaps maybe is for the next meeting. The next meeting we will mainly focus on safe deposit box and related privacy issues. Mr. Chan mentioned that if infrastructure can be put in place for the safe deposit box, is it the case that you are ready? You are ready. The system is ready for you to put in place something like a safe deposit box. We would like to hear more from you. And from your presentation and your document, you respond to issues. One of them is the safe deposit box. We will go into detail in the next meeting. You mentioned overseas experience, but it's very little. You said in your presentation that overseas practice shows that it is not really feasible. Maybe you do more comparison with more countries to see what their systems are like. You can look at their technology, their legislation. Technical development is never a problem. Is it a problem of implementation or problem with the law? Can you give us more information in the next meeting? I think this will speed things up. I don't want a lot of loose ends, Mr. Chan. You asked for more information, Chairman. I agree with that. I want more information in relation to comparison with overseas experience. But I don't want to see information just related to those systems that don't really work. Are there any that actually work so that we can learn from it? If you give us examples and all of them are flawed, then it's useless. I would like to ask for something more. It mentioned in the document some previous discussions. That is very important. Say 2013 March and 2012 June, you had a discussion in the HS panel and you've already got green light to proceed. Give us more background information about previous discussions. You mentioned about a public consultation in 2011 to 12. Can you give us information you collected in the public consultation in relation to the safe deposit box? The information in the document is rather general. We may want to know more about previous discussions. Give us the background information before the next meeting. so that we will have same information. In the information paper supplied in the 3 previous meetings, we have included the safe deposit box. In the last meeting, in answer to the 6 or 7 questions, we answered the PCPD that in relation to safe deposit box, there are 4 countries we have researched on, and we've given information about the implementation of safe deposit box. Since we're going to talk about this in the next meeting, we will give you information and discussions in previous HS panels, public consultations. This is something we can do. That will be the right approach. Maybe you will collate the information on safe deposit box, Dr. Jiang?
To add one point, so certainly we found some examples of countries which attempted to do a safety deposit box, and to be honest, none of them have been successful to the degree that we want to emulate them. There's not a good model that we've seen that we can follow. On the other hand, there are certainly attempts to do record sharing amongst different providers which don't even attempt to do a safety deposit box. It's not a mandatory feature. Not at all. So if you look at, for instance, the most expensive system that I'm aware of in the U.S., the one run by the Kaiser Permanente Foundation, they don't, as far as I'm aware, they don't have a safety deposit box. They don't have these issues. So I don't think it's a necessarily mandatory feature. We've seen other people try, do this without the safety deposit box. All I'm saying is where we've seen people try to do it, they have not really been successful, and that's our quandary, where we simply don't know how we can do this effectively, which is why we have to put it into phase 2. It's not that we don't want to, it's just we don't know how to.
In the information paper supplied, we mentioned that the WHO conducted a survey stating that about 80% of the countries with EHR records don't have this function, and the remaining 20% or so, they are not really successful. And that's in the previous information paper, we have talked about the situation in Canada, UK, and France. As Dr. Jiang said, we will give you detailed information about the studies and the different extent of implementation in the different countries. You can give us a brief presentation next time. You don't have to repeat information that you have already given to us. I believe that the PCPD will respond to that as well. Next, Dr. Joseph Lee. In relation to safe deposit box, I really feel a bit helpless. A few months ago, the administration came to us and explained that for a number of reasons that wasn't put in place, but they don't rule out the possibility that in the next stage it will be put in place. Is there such a concept in private hospital, private clinics? Is there a concept of patient safety deposit box? That is, after a patient has seen you, the patient said that I don't want this information to be seen by someone else. Don't interrupt. You don't have a time limit. You turn this into an electronic system, and the participation is on a voluntary basis. Assuming that this is not electronic, is private hospital or private clinic health record system. If there is no such a concept as a safe deposit box, and you already said that it will not be put in place, I don't mind that it's not there. And you also mentioned whether it's technically feasible. Then there is an assumption that you will put that in place. Well, if you are not going to put that in, just tell me. And if members are not happy, then they will move amendments. You previously said that it will not be added. And if members want that, they may move amendments. If you ask me, I will say, no need. Yes, there is this concept, but at this stage, it's not suitable to incorporate this safe deposit box in the system because it is not there in the first place. So it's not a matter of technical feasibility. When unless the administration is backing down for fear that there won't be enough votes. If members really want the safe deposit box, they may move CSAs and have it voted on. It's not here. It's not in existence currently. It's only the case that it won't be there even when it's in electronic form. You may explore the possibility, get funding approval to explore feasibility. If you can't convince one another, members feel free to move amendments. That is my first point. If you ask me, at this stage, I don't think safe deposit boxes should be incorporated. Please refer to previous records. Another point. This electronic platform. I did not see your presentation, but I won't ask you to repeat it. How is it different from the current system? Nothing. Say the substitute decision maker. It's related to participation. If you don't have the mental capacity to decide, someone else will decide for you whether to participate or not. It's nothing to do with treatment. They are two different things. It seems that we have wasted our time. We have sidetracked. This is a bills committee to scrutinize the bill. If you don't agree, move an amendment. Or you can try to convince the administration for them to change that proposal. Otherwise, we're just not moving ahead. This is never ending. At this stage, I hope that we will proceed more efficiently because we are bogged down on the same point. We can start something else. I might be late, but I've been sitting here for 45 minutes. You already said no, then stick to it. If members don't agree, move CSAs. Don't waste time unless you want to garner vote, so you want to change tack.
預翻足夠。
And this is the fourth meeting. We have to reserve sufficient time for members to ask questions. And so the Privacy Commissioner's Office has given these comments, and we'll have to also await the administration's reply. I think the Privacy Commissioner is concerned about the legislation. And I think the administration can tell us whether it is willing to make any change, or if you're unwilling to do so, then I may want to move my own CSAs. Sorry, Chairman. I think the Privacy Commissioner has not only expressed concerns about the safe deposit box stage. In fact, this safe deposit box concept is not in the bill. And so I understand that one of the Privacy Commissioner's concerns is the safe deposit box. And I think we need to come to a decision next time. And if we can't see eye to eye with the administration, then we'll decide whether we would like to move our own CSAs. But still, we are receiving the replies from the administration. Miss Elizabeth Quat, first round. I agree with Mr. Chen Hengpan, and I think it's good that next time the Privacy Commissioner will be here to discuss with us the safe deposit box. So we'll discuss this when we meet the Privacy Commissioner next week. I want to ask a question about the Code of Practice. So you told us that a lot of things would not appear in the bill, and so even if there is the safe deposit box concept, that will the arrangements will be in the Code of Practice. So I would like to know more about the procedures. Yes, Chairman. There will be a presentation for members later on the Code of Practice. In fact, when we briefed other organizations on the Code of Practice, they thought that the Code of Practice would replace the professional codes of conduct administered by different professional bodies. So the Code of Practice is about, say, if an application is received, should that be dealt with by the EHR office, and then what if the computer system goes wrong, and then is there a need to notify the emergency center? So it's like a menu or a guidebook on the best practices. And also, the Code of Practice contains provisions for also healthcare professionals to follow. So at a future meeting, we're going to give members a PowerPoint presentation on the Codes of Practice. Thank you. So we'll discuss the PCBD next time, and then the code of practice afterwards. Will the code of practice be gazetted? Yes, Mr. Chan. The code is not subsidiary legislation. But as to whether it will be gazetted, yes, we can go back and discuss it. No, because I think the code of practice will contain the operational details. It's very important. And if you still haven't decided whether it should be gazetted, you should come back next time and tell us the factors that you consider, the pros and cons, and what you intend to do and not intend to do, if there is gazetto or if there's not gazetto. And will you can you change the code of practice without having to inform LegCo? So we will inform members at a later meeting. In fact, many codes of practice are not gazetted, but they do have legal effect. I understand that the Privacy Commissioner's Code of Practice has been gazetted. I think whether it is gazetted or not, the legal effect is very important. Now, for example, what you need to do within a certain period of time, and if certain things are not done within that period of time, will there be legal consequences? So perhaps you can explain the details to us later. Dr. Lau. Now, I think I'll start a new area every time I ask a question. And I want to say that I've circled this word accompanying. Now, say an elderly person, maybe 90 years old, and he can't really speak too well, and as a result, the foreign domestic helper may hand me a mobile phone, and I can talk to the son or the daughter of this elderly person. Is that really your question? Yes, I think it's a real problem. And we who work in the front line to know about this problem. And then part 4, C1240. Article 17, application by healthcare providers for registration. So it seems that you're talking about a fixed location here. And the arrangement is different from the hospital authorities' e-health record system, because under the hospital authority, under the internet, the doctors have a password. Doctor has a password and a PIN. Then with the patient's ID number and the patient's PIN, then the records can be viewed. And then Article 17 here, it seems that you're talking, or Section 17, it seems that you're talking about a fixed location. Commissioner. Yes, I need to explain. Section 17 is about a healthcare provider, say a private hospital. and we have to ascertain where the location is, Sha Tin or Central, and so the registration has to also include the location. Dr. Leung is saying that the records can be viewed through a computer. It's not an internet system. This is not an internet system. It's a closed system. So does it mean that the records can be viewed only at a particular desktop computer? I think Dr. Chan can explain as to how the records can be viewed.
There's a few models that we're allowing. So one is what we call the trusted network model, where, say someone like the hospital authority, we trust the hospital authority to be able to manage its network and security and so forth. And therefore we use the what we call the network address of the hospital authority. So anything coming from there we trust. So that there's a trusted network concept. The second one is where we say if we don't trust the network, we have to trust the machine that it's on. So to be able to do that, we're installing some software, which, we call it security software, which sits on the actual machines, which are going to be used to access the EHRSS, and that software can only be installed on, machines that we agreed for it to be installed upon. So then we have control over where this system can be accessed from. I mean, they don't actually have to be physically located in a certain place, but the machine itself has to be, in a sense, software locked by having this this security software installed on it. So that's for the non-trusted network ones. So those are the two essentially those two models of access.
咁嗰部機如果譬如
Say, what if I take the machine back home, and if I can can I access elsewhere? Is it trusted?
Then you're outside the network, so it no longer works, right? If it's a trusted network.
第二個例子
If it's installed on,
Second one.
yes, it could be taken to like a physically different location, but it's still the machine that's trusted. So it's a trusted machine versus a trusted network.
譬如個醫生搬
Say if the doctor, private doctor, relocates his clinic, then
Let's see.
梁議員，
咁我就想提出
Dr. Leung, I think the arrangement here is more complicated than the arrangement at the moment. Now, I'm a private doctor, and if I now need to view the hospital authority patient records, the existing arrangements are more flexible. Say if now I can log into the hospital authority website anywhere. I can access the internet, and then I log in, and then I have the patient's ID number, the patient's password. So I log in, and then I can view the patient's records.
唔需要指
Then there is no need to specify the machine nor the location. And under the current arrangement, seems to be quite complicated. And I want to know whether there is a need to change something that has been in place and working well for a number of years. We've not heard anything about security issues. There is a dual password in place for the doctor and for the patient. And the new arrangement is written into the law. You said the commissioner will specify the format. But for this arrangement, it's written in the law. My question is, why don't you use someone that is already in existence? Why do you specify that it should be a fixed location? It seems that you haven't decided which of the two you mentioned. They are both feasible. It can either be a trusted site or a trusted system or a trusted machine. So if a patient calls me and asks me for an opinion, do I have to run back to my clinic? If it's so inconvenient, I will install a software to forward the my machine onto my phone. Is it legal?
So what we're actually doing is trying to increase the security of the system. It does make it a little bit less convenient in some points, but the main reason we have to do that is because this is if you remember, this is a two-way system, which is different from the PPI EPR, which is a one-way system. So because we're actually having patient data flowing both ways from the machine, we think it's prudent to be more secure than in the current one-way, where you're only reading, you're not writing to the record. So I think that's the reason we have a more secure system in the new design. But I take your point. I think it's something we can always review. It's not actually. I think that security arrangement is not quite the same as what's this. The law doesn't specify the security arrangements. Those are technical security setups that we're taking a shall we say a cautious approach by making it safer, but safer often implies less convenient. So I think that's something that we can always review if we find that there's a lot of questions like that. Oh, this is too much of an inconvenience. We can always review the security arrangements, the technical security arrangements. Those can always be reviewed, I think.
Perhaps you can think about this. You say it's a two-way flow, so it needs to be more secured. I can see that most of the time it's one way. I suggest that you should enhance convenience. Maybe provide for one-way use. Even you think that this is not very convenient, and it's deliberate. It's deliberate because you want to enhance security. Is it necessary to write it into the law? Because for a lot of technical issues, it's not written in the law. Why, on this point, you specify the location? With the current IT level, you won't fix a location. For a lot of people, even for large sums involved, they still use e-banking. Would you please consider a more flexible arrangement? Clause 17, whether the location is specified. I'd like to explain that 17 is in relation to the healthcare provider. At the time of registration, they have to tell us the registered address of the clinic. Then this address will be used as the registered address as the healthcare provider. What Dr. Leung is concerned is that whether it is not as easy as the PPI EPR. As Dr. Zhang said, that the PPI EPR is a one-way system. The EHR sharing system is a two-way system. And we're talking about a lot more participating bodies, so we have to be more cautious. Perhaps for private clinics, using PPI EPR is not as convenient, but for reasons of security and practicality, we have to enhance security. It's not the case that the machine has to be at a fixed location. The machine doesn't have to be in that particular location. So, can someone log in at a different location under the current program, PPI EPR? I think the general interpretation of this clause is that it has to be used at a specified location. Clause 17 is the address of the service provider, maybe a private hospital or a clinic. And whether it's a laptop or a notebook or what, does not matter. The most important thing is that the machine used is traceable. Perhaps I will defer to Ms. Lee. Perhaps you show concern about the clause. For clause 17 bracket 1, if the service provider provides a service at a particular location, an application may be made to the commissioner to become a healthcare provider. It's not about the system, it's about the status as a healthcare provider providing service at a location. And if you refer to clause 49 3b, it specifies that the commissioner will have to keep a register. This is to enhance transparency because patients would like to know what service providers have registered as a service provider before deciding whether to give a sharing consent. So under 49.3b, it sets out that the register must be made available for the public to ascertain certain information so that the member of the public will know whether that clinic is a healthcare provider and where service is provided. In other words, it's only a registered address. It's a location for providing healthcare. Well, I think it's getting more and more confusing. Even for the HA, brain surgeons will have to read images all the time, and they are allowed to see the images at home. So does it mean that the brain surgeon will have to register his home as the registered address? Say I registered my clinic. And there are 3 partners and 3 machines allowed to use the system. And I make arrangements that 5 will be used. 2 of them are notebooks. And I carry them around. That is fine, is that right? That is only a registered address. It's not the address the system has to be used. If you refer to 17 bracket 1, it doesn't specify the location of viewing. There is no requirement in relation to viewing under clause 17. That is only the address of providing service by the service provider. In relation to access, there may be in different forms. First, through a trusted network or a trusted machine. Nowadays, people use desktop or laptops. The most important security requirement is whether this is a trusted machine and not just some random machine using the internet. So if we use a trusted machine, instead of a network, we need a software which is called ELSA. It's installed on the internet, and that on the computer, and that computer can be used. Say if you use a desktop, then you can install this in the desktop, and if you use a notebook, then you can install the software on the notebook, and you can take the notebook anywhere with you. In short, yes. So it's a registered address. If it's what about it's a PC anywhere? Or have you put a lock on this function? Because this may give rise to security breach.
There's technologies now you can install, and there'll be more in the future where people can remote access their own machines.
Yeah.
The fact is, it's still, the machine that you're accessing is still your machine. It's still a trusted machine, and you're enabling access to it remotely for operational needs or whatever. If you want to go to nursing homes, home visits and so forth. So, I mean, and technically, actually, there's no way to block it. There is no way to block it. So, but I think because we know it's from this machine, we can trace all access back to that machine, and the person who registered it is still accountable for access.
咁最後補充一樣嘢咧，既然係咁樣。
If that is the case, then I ask you to provide different types of machine in your platform. Apple, Android, personal computers. And I think the first part of your question was not answered. A company. Please look into whether it should be written in this way. I can't extend the meeting because we have the HS panel at 4:30. So if you don't object, I will adjourn the meeting now for further discussion next time. There are no other matters. The meeting is adjourned. Thank you.